This is the first in a course on radiological interpretation for dental radiographs. The first presentation is on radiographic anatomy. Let's start off with something very basic. This is the commonest dental radiograph taken, the bite wing radiograph. I wanted to start by just reminding everyone about what makes structures on radiographs radiopaque or radiolucent. Here we can see the radiopaque crown of a tooth, and here we can see an amalgam restoration. We see that enamel is more radiopaque than dentine, which is more radiopaque than the pulp cavity. The things that determine radiopacity on a radiograph are obviously the thickness of the object, but beyond that it's the atomic number, the size of the atoms, and the density of the material. Where you have metal with very large atoms and a high atomic number, these will appear extremely radiopaque. This is just to remind you that something which is radiopaque will look white or clear on a radiograph, and radiolucency represents a darker area. It's not uncommon for people to get those mixed up, even at the later stages of the dental course. If we move on to this radiograph, which is a periapical image of some lower incisor teeth, just to remind you again about some very basic terminology. The lamina dura is the socket bone of a tooth. On a radiograph, it's represented by the radiopaque line, the white line that you see running along here. It's a really important structure to recognize because loss of the lamina dura can result from disease, particularly and most commonly inflammation, either periapically or laterally as a result of periodontal problems or lateral canals and root fractures. So it's an important thing to recognize. The periodontal ligament will look radiolucent because it doesn't contain any calcified material under normal situations. And that is the dark line, the radiolucent line, between the root of the tooth and the lamina dura. Incidentally, the periodontal ligament width normally is about 0.25 to 0.4 millimeters wide. That's based on histological studies. No radiologist will sit and measure the periodontal ligament width. You'd be glad to know. But we do look at the relative width of the periodontal ligament in different parts of the tooth attachment, as this may indicate local disease, the most obvious example being periapical inflammation, where the ligament space may be wider around the end of the root of the tooth. Trabecular bone is what we see in between, around here and going up here, which typically has a very lacy structure. When we're looking at the anatomy of teeth, let's not forget that teeth are developing structures in the jaws in childhood, and so it's important to recognize the normal features of a developing root of a tooth. These three radiographs are of the same region over a period of time, and we can see here on the top left-hand side the very typical appearance of a developing root with a flared open radiolucency representing the developing root canal, and the lamina dura running around the end of the developing root. This is not apical pathology. Some people misinterpret a developing root as apical pathology, when in fact it is a normal feature. This radiograph shows the lower right region of the jaw on a panoramic radiograph, and again shows developing roots of teeth. And you can see here this lower right second premolar has finished its crown development and we're going into the root development, and this characteristic open flared developing root and the lamina dura of the developing root is visible here. It is possible to estimate the age of patients using the degree of root development, as you can see from this chart. but you should be cautious about giving exact developmental ages for patients on the basis of their tooth development. This may not correspond with their chronological age. Another anatomical structure closely related to the tooth is the radiolucency that we always see around the crown of a developing tooth. This is called the follicle. Normally, this is quite a narrow radiolucency and is a normal feature and should not be misinterpreted as disease. However, in some cases, the follicle can undergo cystic change and may become visibly wider on a radiograph. When you look at a radiograph of an unerupted tooth, you will see the follicle, and you should expect to see that it is between 2 and 4 millimeters wide from the enamel to the edge of the radiolucency in the bone. Occasionally, particularly around upper canines, the width may be greater, but without there being pathology present. But 2 to 4 millimeters is fairly typical. This is a periapical radiograph of the lower right first molar. Now look at the mesial root of this tooth. Mesially and distally on the root you'll see a rather confusing series of lines. For example, here where we see a line in the bone apparently here, another line here, another line here, and then going across to the other side, the edge of the root here, but then another line going down here. Yet the distal root is very clearly demarcated. In the case of the mesial root, this is because the cross-sectional shape of the root is bilobed, such as the diagram shown on the right. On a radiograph, this will tend to appear as a series of lines corresponding to the edges of the 2 lobes of the root. On the contralateral side, where we have a very cylindrical cross-section, you tend to just see 2 lines. You will see this apparent double root appearance quite frequently on teeth. So here, for example, on this lower left molar, you can see particularly the mesial root has very odd double shadowing. This does not represent 2 distinct roots, just a bilobed cross-section. One very variable feature on dental radiographs is the trabecular bone. Typically, in most patients, this will have quite a lacy structure, and between the roots of lower molars you may often see almost a step-ladder effect. This is fairly normal. Compared with this, lower down in the jaw you may see a more radiolucent appearance, and this is because in children at least, this is a site of bone marrow production. In adults, the relative radiolucency usually remains, and it's just containing fatty connective tissue. However, normal can appear like this, which is a radiograph of the lower right quadrant of a patient, and you can see really almost no trabecular bone pattern at all. This particular radiograph was referred for an opinion about the possibility of there being a cyst present in the jaw. The appearance of radiolucency is, I said, sometimes attributable to bone marrow cavities in the jaw. The reassuring feature here is the presence of the lamina dura along the side of the roots. If this were pathology in the bone, the lamina dura would probably have been lost. The divergence of the roots in this case is due to early extraction of the first permanent molar and the opening up of the space between the premolar teeth. Okay, this is a periapical radiograph of the lower anterior region in a patient. When you look at this, I expect you're thinking it looks very odd. The bone looks extremely radiopaque, and we can see numerous radiolucent lines within the bone, particularly going up between the roots of the teeth. Well, this patient does have unusually dense bone, and this may be due to a bone disease or as a consequence of periodontal disease, or just normal variation. But the feature I'm trying to show you are the radiolucent lines. These are vascular channels, or to be more correct, neurovascular channels. They carry the blood supply to the bone and to the teeth, and also nerve supply. These are present in everyone. In this case, however, we can see them very clearly because of the dense bone. But on normal types of bone, you will see radiolucent lines representing neurovascular canals. These are entirely normal. What we're going to do now is to look at the anatomy on intraoral radiographs, periapical radiographs that is, and we'll do a tour of the mouth. Where we're going to start is in the maxillary anterior region. On the right you can see a periapical radiograph of the upper anterior region. The arrow is pointing at an anatomical structure, a vertical radiopaque band. When we look at the skull, we can see that this represents the nasal septum. This is also the midline of the maxilla, and we can see an arrow pointing at a radiopaque shape which is rounded, as we see here. We can also see the same structure on the contralateral side. This can be seen on the skull here, and you will see that it represents the inferior concha, or turbinate bone. On this radiograph, the two arrows are pointing at radiolucencies, well-defined radiolucencies, either side of the midline. These represent the nasal cavities, the bony nasal cavities. Here, the arrow is pointing at a radiopaque structure, which has a sort of diamond shape, going up into the nasal septum here. This represents the anterior nasal spine. The reason it looks radiopaque is because the bone is thicker in this region. You can feel the anterior nasal spine on yourself just below your nose. Now on this radiograph, we see something else, something different. Between the two central incisors, we can see a radiolucent area. If we look at the skull, this time on the palatal side of the upper jaw, we can see what's producing this radiolucency. It is the nasopalatine foramen, or incisive foramen. You can use either term, they are interchangeable. Just above the incisive foramen, you can see a canal structure, and this is the nasopalatine or incisive canal. The appearance of the nasopalatine foramen and canal does vary from patient to patient. On this individual, we can see that the edges of the foramen actually look more like a pair of typewritten brackets. On this patient, instead of one nasopalatine foramen, we can actually see a little collection of smaller foramina. These are all normal appearances, but just emphasizes that individual patients vary a lot. Now we come to one of the most important bits in terms of interpretation that we've seen so far. The position of the nasopalatine foramen on the palatal aspect of the line of the dental arch means that its position relative to the roots will alter depending on the projection that we use. If we take a radiograph, a periapical radiograph, of the upper anterior region and go symmetrically straight down the middle, the position of the nasopalatine foramen will appear between the roots of the two central incisors. If, on the other hand, we take the radiograph centered over one side or the other and angled as shown on the diagram, you can see that the position of the nasopalatine foramen will tend to appear over the root of the tooth in question. And this is what's shown on the radiograph on the left. The nasopalatine foramen has moved by parallax over the root of the central incisor, and we'll talk more about parallax later. The point is that you should be aware that the nasopalatine foramen can mimic the appearance of periapical inflammation. In this particular example, though, note that you can still see the periodontal ligament of the root of the incisor through the radiolucency of the nasopalatine foramen. Apical pathology arises from the periodontal ligament, and therefore you would not see the normal ligament space present if this were apical inflammatory pathology. Back to our anatomical tour now. These arrows are meant to be pointing at the very thin radiolucent line that you can just about make out. It shows also where we're looking at the nasal septum higher up, which may help you to see it. This is seen best on a skull on the palatal aspect of the jaw and represents the median palatal suture. Some more radiographs. Now the arrows on the radiograph on the left are showing an interface between an area of relative radiopacity and relative radiolucency. The radiograph on the right also shows this effect, which I'll try and outline here with the cursor. This represents the soft tissues of the external nose, the thing you see when you look at an individual. Soft tissues also absorb radiation better than air and therefore will be visible on radiographs. Generally, however, they fade into the background and we don't notice them, but here they're very prominent. Soft tissue shadows in this region can occasionally be misinterpreted as root fractures, so it's important to recognize that they don't just cast a shadow over a particular tooth, but spread across all the teeth and have the characteristic shape of the nose. On this radiograph, the upper arrows are pointing at the same nasal shadow. The lower arrows are actually pointing at the lip line. Again, a soft tissue shadow across the teeth. Now we've moved across. We're actually slightly across to the left side of the upper jaw. We're in the premolar canine region. I hope you can identify the teeth. Now, what are we pointing at with the letters A and B? Well, A represents the floor of the nasal cavity, while B represents the floor of the maxillary sinus. This is an important thing to recognize. For some reason, a name was being given to this point of junction between the nasal and sinus cavities. And the line that you see, the Y-shaped line, is called the Y line of Ennis. You will see this frequently on radiographs. But why did we give it a name? Well, the reason it has given such importance is because one of the commonest diagnostic problems in this part of the jaw is differentiating the normal maxillary sinus from cystic lesions on teeth. You should be looking for this characteristic shape of the junction between the nasal cavity and the maxillary sinus as a sign of normality. Here we see it again. I hope you can make out this inverted Y shape, the Y line of Ennis. Here we're on the contralateral side, on the upper right, and here we see the typical Y line of Ennis again. However, someone asked me about this radiograph and suggested that maybe this would be the Y line off the edge of the radiograph, and that this area of radiolucency might actually be a cyst arising from one of the two teeth. Well, if you're ever presented with this problem, one approach is to turn up the brightness and the contrast on your radiograph, or if it's a film, to bright light it from behind. Now when we do this for the radiograph on the left, we can see on the right that there are numerous thin radiolucent lines traversing the area. These are neurovascular channels in the wall of the maxillary sinus, grooves in the bony wall. You will only see this in anatomical cavities. You do not see it in cysts, and this is a good way of differentiating between pathology and anatomy in this case. Incidentally, if you're wondering what this vertical radiopaque line is, this is a ridge in the wall of the maxillary sinus, which we call a septum, and we'll see more of those shortly. Here we see a radiograph of the upper right lateral incisor, canine and first premolar teeth. Again, we can see our Y-line of Ennis here, with the sinus here and the nasal cavity up here. But the arrows are pointing at soft tissue shadows. The white arrows are pointing once again at the edge of the external nose. But what are the red arrows pointing at? Well, they're pointing at the nasolabial fold. Back here, the soft tissues of the face are thicker compared with here, and this is the nasolabial fold running down here. We now move on to a radiograph of the upper right posterior teeth, and we've got a few structures marked here, so let's try and explain what they are. A, on the left hand side of the picture, posteriorly in the patient, is pointing at a radiopaque area. Radiopacity, remember, is either a denser structure, a thicker structure, or one with a higher atomic number. In this case, it's because the structure is thicker and probably a little bit denser. We are looking at bone, and we're looking at the zygoma of the cheekbone, which has just come onto the picture. At B, the arrow is pointing at a septum, another septum. Remember, we were just talking about that on the previous radiograph. This is a compartment in the maxillary sinus. It isn't going to be completely running through the sinuses. Think of it as a ridge in the wall. C is the floor of the maxillary sinus. In this case, the Y-line of Ennis would be off the film, but it would be in this sort of region here. Here we see another radiograph along with the dried skull, and we can see point A, the zygoma, now showing very clearly here on the photograph. B is a septum, which would be within the maxillary sinus, and C is the floor of the maxillary sinus. Again, on the upper right jaw, we can see a different patient, or two different patients here on the radiographs, and we're pointing again at the zygoma. On these two patients, the shape of the zygoma is represented by a U shape on the radiograph, as shown on the upper right radiograph by the black arrows. The red arrows that you see here represent the lower border of the zygoma going back into the zygomatic arch, which would be here on the skull. On the radiograph beneath, we again can see the U shape of the zygomatic process of the maxilla and the inferior edge of the zygoma going back into the zygomatic arch. We're now on the upper left for a change, and again I'm showing you here the maxillary sinus floor, which is running along as shown here, but the arrow is pointing once again at a septum within the maxillary sinus. The radiograph on the bottom right shows a patient who has many different septa within the maxillary sinus, so you get a kind of arcaded effect. This again is normal but can be very confusing because it's easy to misinterpret isolated areas of this maxillary sinus as being apical pathology. So be cautious about interpreting apical pathology when it's superimposed on the maxillary sinus. Incidentally, the Y-line of Ennis is just visible on the edge of this radiograph, just to orient you there. And this is the floor of the nasal cavity running back. On this radiograph, once again, we're seeing the black arrows pointing at the maxillary sinus floor. But here we now have a different feature which we've not talked about. The red arrows are pointing at a thin radiolucent band which is traversing the image from distal to mesial. This is a neurovascular canal. We've seen them before in the maxillary sinus. But here this is a very prominent radiolucency. And this is the groove in the lateral wall of the maxillary antrum caused by the posterior superior alveolar neurovascular canal. Both these patients show a phenomenon which occurs quite frequently after the extraction of teeth in the posterior maxilla. This is called pneumatization of the alveolar bone. When teeth are extracted, instead of bone filling in the socket, the maxillary sinus will expand into the alveolar ridge. This is a useful feature to recognize, particularly with the case shown on the left side of the image. You have there an isolated upper molar. If you were to extract that tooth at some point in the future, obviously you would first have to separate it from the bridge, but if you then extracted it, you would have an increased risk of exposure of the maxillary sinus and the creation of a communication, or possibly of fracture of the maxillary tuberosity. This radiograph, a panoramic radiograph, shows a normal variation in the size of the maxillary sinus. You will see that the maxillary sinuses on both sides are extremely large, with pneumatization down in between the roots of the teeth, and the anterior extent of the maxillary sinus, certainly on the patient's left, reaches the midline. This is not common, but is a normal variant, so it is conceivably possible to expose the maxillary sinus and cause an oroantral fistula by extraction of a central incisor. Here is an intraoral radiograph of a different patient who also has hyperplastic maxillary sinuses. In this case, we're looking at the central incisor on the right in the middle of the image, but the radiolucency above is the maxillary sinus. Clearly, in these individuals, the normal Y-line of Ennis, which we've shown you before, would not be present. It's very easy to misinterpret normal variations like this as representing pathology, cysts in the jaw. Returning to the posterior maxilla, the arrow here is pointing at the bone distal to the last standing molar. This is, of course, the maxillary tuberosity. This radiograph shows again the same region. There is an interesting finding here, because if you count the number of molars, you should identify 4 molars, which is one additional to the normal number, and we have a supernumerary third molar present. Indeed, the erupted third molar is probably the extra tooth, and the unerupted tooth is probably the real third molar. But the arrow is pointing at a structure at the bottom left-hand side of the image. What is this? Well, it's actually part of the mandible. This is the coronoid process of the mandible, which occasionally may stray onto the corner of the image of a upper posterior molar. Here we see a patient or a radiograph of a patient who's been very tolerant and the radiograph has gone a long way back into the mouth. Beyond the tuberosity, we can see a little finger of bone. Now, what is this? Well, it's the pterygoid hamulus. The arrow above that is pointing at the lateral pterygoid plate on the skull view, but we can just about make this out on the radiograph. It's a very, very faint radiopaque structure here. This is the lower edge of it going across. Again, a posterior periapical radiograph. And just to remind you about the zygoma appearance, here we see the U shape of the zygomatic process of the maxilla, and here we see the lower edge of the zygoma going back into the zygomatic arch. Let's move to the lower jaw. We're now in the middle of the lower jaw, the lower anterior region, and we can see well below the teeth a small radiolucency surrounded by a relatively radiopaque area of bone. On the skull, and if we look on the lingual aspect of the mandible in this region, we will usually see a small hole, a foramen. This is called the lingual foramen and carries a few terminal fibers of the inferior dental canal out into the floor of mouth, and indeed there may be some flow of neurovascular structures from the floor of mouth into the mandible in this region. It probably is the most insignificant foramen in the body, but it's worth noting it's there because it gives you an indication of the midline of the jaw. Now, that's not terribly important where there are teeth present, but if in a patient who's, for example, edentulous in this region and who may have a little retained root fragment, it helps you to localize where you are on the radiograph in relation to the mouth. Here we see the radiolucency again, but the radiopacity around the lingual foramen is shown to represent the thicker bone in this region, the lumpy bone that you can see just below the lingual foramen on the skull image. These are called genial tubercles and are the site of attachment of the genial muscles, genioglossus and geniohyoid. It's really a bone attachment for the tongue as much as anything else. On an occlusal radiograph, here we see a true occlusal image where this is the floor of mouth and out here would be the lips, and you can see the genial tubercles in this case in plan view. Again, in this region, just to remind you, there's our lingual foramen down here. The little bit of denser bone is the genial tubercle shadow. We can see this very clear V-shaped ridge running to the midline. Now, these are called mental ridges. They're basically just the shape of the bone of the chin. So if someone has a very prominent chin, you'll see very prominent radiopaque bands forming an upturned V. Some patients won't show this feature. It all depends upon their particular facial shape. We've now moved a little bit around the jaw here, and we're looking at the lower left premolar and molar region. Now, the black arrows here are pointing at a canal structure, one which you probably know very well. Now, we can't see it on the skull because it's within the jaw, but it represents, of course, the inferior dental canal. Typically, this should have a lamina dura, in other words, a thin, white, bony line, both at the top and bottom of the canal, although you'll find very quickly that in many patients, only one of those lines is clearly visible, and rarely neither is visible, and all you can see is a very faint radiolucent band running through the jaw. Here's a periapical radiograph of the lower left. We're looking here at the canine, first premolar, second premolar, and here a second molar, tilted in because the first molar has been extracted. But there's a radiolucency here with which you should be very familiar. then you should certainly remember. On the skull, this is of course, the mental foramen. Why is this so important? Why am I emphasizing it? Because it tends to appear close to or over the apex of a premolar tooth, and it is so easy to misinterpret this as periapical inflammatory pathology. So you've always got to try and remember that this anatomical feature will lie in this region, most commonly around the apex of the second premolar, but not always. We've now moved more posteriorly, and we're looking at a lower left 7 and lower left 8. The arrows are pointing at a band of radiopacity going across these two teeth. What is this structure? Well, on the skull, we can see it as a ridge of bone on the buccal aspect of the mandible. This is the external oblique ridge, something you'll be familiar with clinically when you're doing an IDE block. You feel for that structure as part of your landmark identification. The radiograph on the right shows that the structure does appear on images. Again, on the lower left, different patient of course, and we can see down low below the apices of the teeth a radiopaque ridge. Now this isn't the external oblique ridge, it's far too low in the patient. But if we look at the lingual aspect of the mandible in this region on the skull, we can see a very clear edge at this point, below which the bone is thinner. The thinner bone below this ridge accounts for the relative radiolucency of the bone down here. The ridge is the attachment site of the mylohyoid muscle, the muscle that really contributes most to the floor of the mouth. The radiolucence area below the mylohyoid ridge, as I said, is because the bone is thinner buccolingually in this area, but this represents the submandibular fossa. In the patient, the submandibular gland lies in this region. Here we see another patient in the same region, and I'm just going to point out some of those key anatomical features. We have the external oblique ridge. We have the mylohyoid ridge. We have the ID canal, or mandibular canal, and we can see there I've arrowed just the lower border of the canal, but you can see a white line, a lamina dura, higher up, which is the upper border of the canal. We've got the relative radiolucency of the submandibular gland fossa, or submandibular fossa for short. And one other structure right at the bottom is the band of dense bone, the cortical bone at the lower border of the mandible. We don't often get this on the radiograph because a patient has to be pretty tolerant to accommodate the imaging plate that low down, but nonetheless you can occasionally see it. You will certainly see it on panoramic radiographs. Well, we've got a real selection of radiographs here, all showing third molars. And it's important to look at third molars if they're going to be extracted in the context of their root formation and their relationship to the anatomical structure of the inferior dental canal. When we look at the radiographs for the relationship between the roots of third molars and the inferior dental canal, we're looking for very characteristic signs, some of which are shown on these radiographs. We may be looking for deviation of the roots, as is seen on the top left radiograph. You can see the roots of the third molar are dilacerated or bent in a distal direction at the upper border of the canal. The radiograph on the top right shows an ID canal overlying a developing root of a third molar, and the canal doesn't smoothly go around the root, it has a fairly obvious angle at this level.
So when we're looking at radiographs for the relationship between third molar roots and the ID canal, what are the key features we're looking for? Well, the most important ones that show a close relationship are darkening of the root, loss of the lamina dura of the canal where it overlies the root, but also deviation of the canal, deviation of the roots. Have a look at this example here. This is a part of a panoramic radiograph of a patient with an impacted lower third molar. We'll look at the inferior dental canal as it overlies the roots of the teeth. The canal seems to deviate slightly from its normal path. The canal looks narrower where it overlies the roots, and the root looks darker. These are very key signs of a close relationship between the canal and the roots rather than a mere superimposition. Modern imaging practice allows us to occasionally use cone beam CT to produce three-dimensional images, which allows us to assess very accurately three-dimensional interrelationships. And this example, which I've just shown you, was undergone a CT scan, and we can see now on the images on the right that the actual relationship between the canal and the roots was very intimate and close. Here we're seeing a sagittal view, here we're seeing a coronal view, and here we're seeing an axial view. And you can see, I hope, that the canal is going between a bifurcation in the root system. You can see it here on the axial view as well. So if this patient had their third molar removed, there would be a very high risk of damage. Which brings us on to the subject of how we localize objects on radiographs. While most ordinary radiographs are of course simple two-dimensional images, and we are limited in how we can localize objects. The first method we can use is to use two views at different angles. That's a bit like using our two eyes to look at objects and gaining a three-dimensional feel. This is made more formal using a parallax shift technique. And finally, the way we can do it is to use three-dimensional imaging, as we've just seen, cone beam CT. Two views at different angles is relatively simple to carry out in dental practice, and will probably be the method that most of you use if you need to localize an object. Here's a practical example. This patient attended with pain under their lower denture. Clinically, there was a definite sore spot on the alveolar ridge in the lower right premolar region. So the dentist took a radiograph, a periapical radiograph, which you see here. Now I'm sure you've all identified a retained root is present. We can see it very clearly here. But in order to localize this root relative to the inferior dental canal, which you can see running through here, coming up to the mental foramen here at the crest of the ridge, the dentist took an occlusal projection, which you can see on the right hand side. Now this allows us to see that the inferior dental canal is running on the lingual side of the root, leading to the foramen here. There's our genial tubercles, just to localize the midline of the mandible, by the way. This is relatively good news for the dentist, because it means that if bone removal were required to remove this root, it could be done from the buccal aspect without risk of exposing the inferior dental canal. But parallax is widely used by dentists, and this is a more sophisticated version of using two images. I'll give you an example to try and explain the principle. This is a radiograph taken straight down the midline of the maxilla. I've actually taken it on a dried skull, so the image looks quite high contrast compared to a real patient, where soft tissues tend to make the image rather grey. In the midline between the two incisors, you can see our old friend, the incisive foramen. And we're going to use that as an example to try and prove parallax to you. If we're going to do parallax, we would take two radiographs with at least a 20-degree angulation difference between them. So the radiograph you now see on the right-hand side of the picture was taken slightly from the left-hand side of the patient. So we're seeing the same teeth, we're seeing the same foramen, but at a different angle. You will see that the image of the incisive foramen has moved over the root of the upper left central incisor compared with the first radiograph. We know from the parallax rule that if an object moves in the same direction as the perspective shift, it is on the lingual aspect, and if it moves in the opposite direction, it is buccal. From the example before, the radiolucency of the incisive foramen moved in the same direction as our perspective shift, and therefore we proved that the incisive foramen is lingually or palatally positioned. We can use this technique of parallax shift as here for endodontic uses. In this case, we've uncovered the mesiobuccal root of this upper six from superimposition on the palatal root by a parallax shift, as shown here. So we just changed our angulation a little bit. We can also use parallax to localize unerupted teeth. This patient has an unerupted canine, a common situation where we want to localize tooth position. In this case, we take another radiograph, more posteriorly positioned, so our perspective has changed from the front of the patient to the side of the patient. What can we see here in terms of the shift, the parallax shift of the canine tooth? Well, on the anterior radiograph on the left, we can see that the crown of the canine is just slightly overlapping the edge of the lateral incisor and overlapping the first premolar roots quite a lot. The picture taken from a more posterior position shows the crown of the canine tooth overlapping the lateral incisor more than previously, while it is overlapping the roots of the first premolar less. So as our perspective moves distally, the crown of the canine has moved mesially relative to the adjacent teeth. It's moved in the opposite direction. So using our basic rule of same lingual, opposite buccal, we know that the crown of that tooth is buccally placed. Parallax does not have to be done in a horizontal direction. It can be done in any direction shift. And here we show the same example, the same canine tooth with the posterior periapical here, but in this case accompanied by an occlusal radiograph. Now think to how we take occlusal radiographs. These are taken with a fairly profound downward angulation, probably about 55 degrees in this situation. Look at what the crown of the canine tooth has done relative to the incisor and the first premolar. As our perspective shift has moved to the occlusal radiograph, that is looking down on the patient, the crown of the canine has moved over the crowns of the premolar tooth. This means, once again, that we've proved that it's moved in the opposite direction to our perspective shift, that it is buccally placed. One very common combination of images that dentists use is to do parallax between a panoramic radiograph and an anterior oblique occlusal, as shown here, where there are two unerupted maxillary canines. With a panoramic radiograph, we tend to assume a horizontal beam angulation from behind, so think of it as just a straight tube. The occlusal radiograph is taken with a 60-degree, 65-degree downward beam angulation. So we've got quite a lot of tube shift, perspective shift between the two images. As our perspective moves up from the panoramic to the occlusal radiograph, can you see that the canines appear to also move up the roots of the incisors? Using our slob rule and knowing that same directional movement means lingual, opposite movement means buccal, we know that these canines are palatally positioned. As I said already, parallax can have its uses in endodontic treatments. Here we see a fairly reasonable periapical radiograph, which includes the upper right four, which has obviously undergone endodontic treatment. Now we know that upper first premolar teeth usually have two roots, but here we can only see one root and one root filling. By using a parallax shift of the same patient, we've removed this superimposition, and we can see now two root fillings. Have a think for a moment, which root canal is the arrowed root filling lying in using parallax? Well, the picture on the left is taken from a posterior perspective from the side of the patient. The picture on the right, the canine film, is taken more from the front of the patient. So our perspective has moved mesially. So where the arrowed root filling has moved with us, while the other root filling has moved in the opposite direction, as we have moved mesially. Therefore, using our slob rule, the arrowed root filling, which has moved in the same direction as our shift, is the lingual or palatal root filling. Here we see a real challenge for you to try and do some parallax. This patient has a real jumble of teeth going on here, so let's try and orient ourselves. Up here we can see the nasal septum. We can see the midline median suture here. You can see it running through between the two central incisors. There's the left lateral. Here's the right lateral, which is ectopically positioned, although it was erupted. But I hope you can also see a rather bulbous shape to the end of this root. On this radiograph we can see it here. Now, there's nothing wrong with the root of this incisor. This is a supernumerary tooth, a mesiodens, which is superimposed upon this root. Now, have a think for a moment and tell us, where is that supernumerary position? Is it lingual or palatal to the root of the incisor, or is it buccally placed? Well, as our perspective has moved in the direction shown by the arrow, you will see that the supernumerary tooth has moved in the same direction relative to the root of the central incisor. So that means it must be lingually placed or palatally placed in the upper jaw. A 3D alternative to parallax is cone beam CT, of course, and this is increasingly used as a means of localizing maxillary canines when they're impacted, but most specifically in the context of where there has been, or where there is thought to have been, resorption of the roots of lateral incisors. And here we see the axial view of this patient, and we can see here the tip of the crown of an unerupted canine, and here the resorption of the root of the lateral incisor. On the picture here, which is the coronal view, you see very clearly the resorption of this tooth. These three-dimensional methods can be very useful for other aspects of dental practice. In this case, we had a patient where an extraction was performed and a root was displaced into the maxillary sinus. We can just make out the root inside the maxillary sinus on the panoramic radiograph. Although, of course, when I say inside the maxillary antrum, I am being a little presumptuous, because a two-dimensional radiograph does not really localize an object, and that root could have been in the palatal soft tissues or indeed the buccal soft tissues. The only way of accurately localizing it in this case was to do a cone beam CT scan, which I'm sure you can see very easily shows the presence of the root centrally within the maxillary sinus. Incidentally, the maxillary sinus is not looking normal. It should be black, like this little bit up here or in the nasal cavity, because that's air, and a sinus should contain air. But in this case, because of the trauma introduced by the displacement of the root, this maxillary sinus has become full of inflamed mucosa, and that's what's holding the root in that rather precarious position in the middle of the maxillary sinus.